So what we're talking about today, so what I'm going to be talking about today is promoting maternal mental health during and after pregnancy. And I'll specifically talking a lot about our program MCPAP for moms as I talk about that. So perinatal depression is really common, and when I use that term, I'm referring to depression that occurs during pregnancy or within the first year of postpartum. 1 in 7 women are going to experience depression during that time period. And it's actually twice as common as diabetes. So if we think about depression, obstetric care, OBs always screen for diabetes because it's a part of routine care. And depression is actually twice as common. And a lot of times people hear about postpartum depression, and I think it's important to actually think about this as perinatal depression. Because of the women who develop postpartum depression, 2/3 of them actually are going to develop depression before the baby's born. So about 1/3 of women enter pregnancy with pre-existing depression. About 1/3 of women are going to develop depression during pregnancy, and another 40% develop depression during the postpartum period. So it's really important that we begin to think about this far before the baby's born. Ideally, we're even talking about addressing this preconception. So planning for what to do if someone's struggling with depression and they become pregnant, or planning a pregnancy. Also important to acknowledge that 1 in 3 fathers in families struggling with maternal depression experience postpartum depression. And when it occurs in dads, it often appears very differently. So they may present, how it may present differently in dads than in fathers and in mothers is that sometimes it presents with substance use. So someone who didn't previously, drink, for example, a lot or abuse alcohol might begin to abuse alcohol. And you also see a change in work or social functioning. And it may present that way as opposed to sort of typical symptoms of depression, or that may be what the other partner notices. The other thing I want to make note of is that adoptive families also have similar rates of postpartum depression of birth parents. So this is not, while we do believe that postpartum depression and perinatal depression in general is biologically based, adoptive parents actually also have similar rates. And PPD refers to postpartum depression. And it's well established that perinatal depression has an impact on mom, on the child, and really on the whole family. So during pregnancy, depression is associated with poor healthcare use, increased use of substances, and preeclampsia. And then it affects birth outcomes, has been associated with low birth weight, preterm delivery. And then it also, in the first year postpartum, associated with difficulty with mom and baby attaching or bonding. And then also even later on, it's been associated with kids of moms with maternal depression having increased risk of having their own anxiety and disruptive disorders. And then also suicide. Suicide is the leading cause of death among women with depression, among postpartum women with depression. And also I want to point out that postpartum depression is the leading cause of toxic stress. So you may be familiar with the ACE study. This is the Adverse Childhood Experience study. And they looked at, what are they looked at adverse childhood experiences and how they impact outcomes later on in life. And adverse childhood experiences in general are really some of the most basic causes of adult risky health behaviors, and also morbidity and mortality, and ultimately increases healthcare costs. And depression is one of the leading causes of toxic stress. And it also has, intergenerational transmission of this sort of health risk and disparity. And this often happens with an absence of social emotional buffering, such as with PPD, because you don't have that buffering that you may not have that buffering that you would have if someone doesn't have depression. And there's some evidence that if you can, so this talks about, maltreatment, parental substance use, and postpartum depression. And there's some evidence that if you can provide supportive relationships and safe environment, it can improve outcomes for all children, and especially those that are the most vulnerable. And it says between 75 and 130 of every 1,000 children live in a home where they're affected by toxic stress, and depression is one of those things. And there's also evidence that if we treat maternal depression, that's associated with improved outcomes in depression and also other disorders in a mother's child. So the STAR-D study was a study where they looked at very, very large study where they looked at treatment for depression. In that study, they had 150 mother-child pairs in 8 primary care and 11 psychiatric outpatient clinics across the U.S. And what they noted was that after they finished the study, one of the things that they noticed was that continued effort, and one of the conclusions, I should say, was that continued efforts to treat maternal depression until remission is achieved was associated with decreased psychiatric symptoms and improved functioning in the offspring. And so if you treat maternal depression in general, there's some thought that, the thinking is it can improve outcomes among the offspring. And if you treat the maternal child dyad, that shows promise of even better child outcomes, because then you're treating both mother and the infant or the child. So, it's well established that this is very common. It's got a negative impact, and it affects mom. We talked about the dad, adoptive parents, and the mother-infant dyad, and children later on. And unfortunately, despite that that's the case, it's underdiagnosed and undertreated. So even if women screen positive for depression, less than a quarter of women are actually going to get to initial mental health appointment. And this is due to a number of reasons. Patients may feel uncomfortable talking about it. Providers may not be trained. The systems may not be integrated. So you have women who may not disclose symptoms or seek care, unprepared providers with limited resources, unutilization of treatment, and poor outcomes. So what we're going to talk about today is how we can be able to overcome some of those things. And ideally be able to break this the negative transgenerational impact and be able to optimize mental health to do that. So if we think about sort of going down these generations, the goal is to be able to break this so we don't have this transgenerational impact. And one of the ways that this can be, in the perinatal time period, is really ideal for the detection and treatment of depression. So in general, 80% of depression is generally treated by primary care. And in the obstetric time period, every time a woman sees an obstetric provider is an opportunity to treat them and engage, to screen them and also engage them in treatment. Women are often seeing providers during this time period more than any other time period during their childbearing years. So frontline providers really have a pivotal role of all types, and I'm including pediatricians, any really provider or healthcare, someone or allied healthcare professional who interacts with pregnant and postpartum women. I think everyone who interfaces with pregnant and postpartum women can play a critical role. And one of the key places that can happen in the medical setting is in obstetric and pediatric practice. So if we can transform those practices to be able to include depression care, this could provide a solution by screening women in these settings and helping link them with care. So I'm going to describe now what we're doing in Massachusetts in order to address this. In 2010, Massachusetts passed the Postpartum Depression Act, and that established a Postpartum Depression Commission. That commission then established a regulation saying that if people screen, they need to report it. The other thing it established was funding for our program, MCPAP for Moms, which stands for the Massachusetts Child Psychiatry Access Project, and I'll talk a bit more about that. So MCPAP for Moms really has 3 core components. One core component is education. So we provide education for providers working with pregnant or postpartum women. The other thing that we do is we provide consultation. So if a medical provider is working with a pregnant or postpartum woman and they have a question, they can call us and we can answer. We can provide telephone consultation and answer questions. And the other thing we do is care coordination. So say if a provider calls, they speak. Our goal is to call them back within a half an hour. If one of our perinatal psychiatrists speaks with for example, an obstetric provider, and they're looking for therapy for the patient, we can ask our care coordinator to outreach the patient and help link her with therapy in the community. So those are really the 3 core components of the program. And so this is who we provide telephone consultation to. It's really obstetric providers and midwives, family medicine providers, psychiatrists, primary care providers, and pediatricians. We've taken calls also from ERs, we got a call recently from attending on a Huntington's unit because they have pregnant patients there. So really any medical provider who's working with these women. And one of the things I want to, the goal of MCPAP for Moms is really to be able to build the capacity of frontline providers in order to be able to leverage the limited resource of perinatal psychiatrists and also help link women with therapy in the community. So in general, it takes a long time, as I'm sure a lot of people on this webinar are aware, to get treatment with a psychiatrist, and even more time often for a perinatal psychiatrist. And so we know that that's really hard, and will never be enough of us to see all these patients, particularly when practices are screening and we're identifying more women. So our goal is to really help these frontline providers be able to provide evidence-based treatment, and that way it leverages us as a limited resource. And our other goal is that, so for those of you on the call who may not be a medical provider, it also provides an area where you can refer people to. So for example, a lot of what we tell, so for example, if someone's a home visitor, or if they're working as a doula, or they're not providing, may not be a prescriber, but they're working in settings where they're interacting with women in these settings, the goal is that if we build the capacity of the medical community to be able to treat these patients, you can then refer mom to go back to her provider, and the provider can actually provide that care. Our calls do need to come directly from medical providers, because they're the ones who can actually, provide, if Medicaid use treatment indicated, they can do that. So what you can do, if you're not someone who is a prescriber, or who is in one of those categories I just described, what we would encourage you to be doing is encourage mom and family members to visit our website. We have, I believe it might be, I think it's on the next slide. We on our website, we have a Mothers and Families tab, and moms can go on there, they can look up some resources, they can put in their zip code, search for a support group. The other thing you could do is encourage mom to contact your primary care or obstetric provider, or really any of those providers that we just had on that last slide, and the patient can then ask their provider to call MCPAP for moms. And with permission, you can also contact the patient's primary care or obstetric provider and recommend they call MCPAP for moms. And we absolutely get calls like this. We've had psychiatrists call us and say, I'm calling you because my patient told me I should. And we've had providers call and say, I've had OBs call me and say that someone screened the patient, a home visitor screened the patient, and they were concerned, they let me know, and now I'm calling because I want to help the patient get help. So the goal is that we're sort of building the safety net among the medical community to treat the patients, and thereby everybody has a referral source. Everyone has someone where they can tell the patient to go if they detect depression, say, for example, a home visitor who may be screening patients. So a little bit more details about how it works. So if, say, for example, a patient's being screened in an obstetric office and they screen positive for depression, what happens is that OB/GYN can call us, they speak with our care coordinator then pages the perinatal psychiatrist, we then have a phone call with the OB/GYN, and then we have a telephone consultation at that point. And there's three things could happen out of this. One thing could be that we have a telephone consultation, we answer their question, and it ends there. The other thing could happen is that we may have a face-to-face consult, because say, for example, if the provider said, I'm treating this patient, but I'm still a little bit uncomfortable, I'm not sure what to do, can you please see them? We can do a one-time face-to-face consult and then give the recommendations to the provider with the understanding they're willing to manage the patient's medications. And the other thing that happens a lot is we have therapy. So whenever we're on a call, we always ask, is the patient in therapy? Can we help the patient? Can we help the patient access therapy? And we always encourage the providers for therapy. And a lot of times, medications aren't indicated, and the whole call is about therapy. So another key thing that we do is we provide the medical provider and the medical practice can ask us to provide care coordination for the patient, and then we can either give the practice resources to give to the patient, and at other times we outreach directly to the patient to give her resources. And we really we encourage all obstetric and pediatric providers to screen for depression. And really the goal is that we're screening for depression. We encourage OB practices to screen for depression at 2 time points during pregnancy and at 6 weeks postpartum, and then at 2 weeks postpartum for high-risk patients. And that way, we make depression as a routine part of obstetric care, just like diabetes, because it's, as we mentioned earlier, it's twice as common as diabetes in pregnancy. And then we also recommend screening during well child visits, because ideally a woman's screened in pregnancy and then up through the first 6 months postpartum, because a lot of times the OB care drops off after 6 weeks postpartum, because that's the way obstetric care is often designed. So what we recommend to pediatricians is to screen in pediatric practice is to screen within the first month, at 2 months, at 4 months, and at 6 months. And one thing that we're really excited about is in the past year, the EPDS, which is the Edinburgh Postnatal Depression Scale, which is a validated screen used to screen for depression and pregnancy in the postpartum period, that was actually recently added to the Massachusetts Survey of Well-Being of Young Children. So this is actually now embedded in the SWIC. And this SWIC can be downloaded actually at the MCPAP website. And we also have a toolkit available. If anyone's here from a pediatric practice, we have toolkits available for the pediatric practice. We also have toolkits available for obstetric practices too. And the other thing I wanted to mention was that screening is another thing we're excited about, is that screening is now reimbursed once during pregnancy and once postpartum for MassHealth patients. So the code that's used is S3005. If behavioral health need is identified, the modifier U3 is needed. And if no behavioral health need is identified or just the screen isn't positive, then modifier U4 is used. So now I'm going to switch gears and talk a bit about what do you do if you're with a patient, whether you're a medical provider, an allied healthcare professional, anyone coming into contact with pregnant or postpartum women, or a researcher thinking about this topic. I'm going to provide an overview of what the treatment is and also how we can assess depression among this population. And one of the things that is important is to note that there's a bidirectional relationship between depression and infertility. So we talk a lot about pregnancy and postpartum depression and pregnancy and postpartum. We also want to note that this often occurs for women that are trying to conceive or struggling to conceive. And there's this bidirectional relationship where if women are struggling with infertility, that can increase the risk of depression. And then the depression and anxiety can also increase the risk of infertility. And so preconception planning is really critical. So attempting conception can be really stressful for a lot of women, particularly if they're struggling with it. And there's a lot of evidence-based treatments for depression and anxiety during this time period, including therapy. And I really want to impress that particularly if someone's on psychiatric medication, that preconception is really an opportunity to plan and to streamline treatment. So ideally, someone doesn't get pregnant and then say, uh-oh, I'm pregnant, I'm on a psychiatric medication, or maybe more than one, what do I do? And maybe they stop their meds and we see this a lot where people stop their meds because they assume that's what they should do and then they relapse into their illness. And what we really would love to see happen is where someone's anticipating, you're planning a pregnancy or you're getting infertility treatment, for example. So let's talk about how we can optimize your mental health before you become pregnant. Or if you're planning this pregnancy, let's plan out what we're going to do when you become pregnant so there's a plan in place. And we don't see this sort of precipitous discontinuation of medication, and then which often leads to relapse into illness. Because a lot of those crises can be avoided with some careful planning ahead of time. So when we think about, what puts people at risk of having depression during this time period, the biggest risk factor for a depression is the duration and the number of depressive episodes. So the more often someone's been depressed and the longer the episode has been, the higher risk they're going to be for depression. Other risk factors include if someone has a personal history of postpartum depression, that's a risk factor, certainly. A family history of postpartum depression, and also anything when there's a history of mood changes, so particularly related to hormonal changes. So if someone, for example, has had mood changes related to hormonal contraception, or if they've had premenstrual dysphoric disorder, if they get severe PMS, those are often indicators that they may be at higher risk of depression during the perinatal time period. And one of the ways that the most widely used tool to screen for depression during this time period is the EPDS, and that's the Edinburgh Postnatal Depression Scale. Yeah?
Excuse me, have you been moving your slides forward?
Yeah, I have.
Okay. For some reason they're not showing up here. If anyone else has noticed that their slides aren't moving forward, please let me know by sending me a message. Maybe it's just an issue here. Thank you. Sorry to interrupt.
I'm on slide 31.
All right, thank you.
Okay, well, I hope people are seeing them because I'm moving them forward. I hope people can see my slides because I'm seeing them on here. So I was talking about the EPDS, right? So that's validated, very widely used tool. It's validated in pregnancy, and in the postpartum period, it's got 10 items, and it's important to note that it does ask about self-harm. So whenever this is administered, there just needs to be a plan in place to make sure that if someone answered positive, not suicide question, or the self-harm question, that there's a plan in place to be able to manage that. And in general, so the EPDS goes from 0 to 30, with 0 being...
Dr. Byatt, I'm sorry, it does look like no one else is seeing your screen move forward. Let me see if...
That's weird. Huh. That's odd.
I may restart the webinar and see, because do you still have your GoToWebinar dashboard and everything going?
Yep, mine's right up here. I see the dashboard, and it's every time I talk, the yep. Okay, so I'm doing show my screen. Let's see if this works. Does that work now?
Yes. Yay.
Thank you.
Oh, God, that's unfortunate. You guys were like, we're spending a long time on one slide.
I know.
That would be not a good present. That's really, oh, well, that's unfortunate. Well, we can send the slides later, so hopefully people will be able to look at the slides. But no, I definitely only spend a few seconds on each slide. So.
Okay. Now, and they will be posted on Spark's website probably next week.
So people can view them. Great.
Yeah.
Good. Cool. So they can catch up. Okay, good. So, yeah, well, thank you. I'm glad you pointed that out. Thank you for addressing that. So, with the EPDS, it generally, so it goes from 0 to 30, 30 being, severely depressed, 0 being not depressed at all. And generally, if someone has a score less than 10, depression is going to be unlikely. Most of those women are not going to meet the criteria for depression. If you have a score between 10 and 12, those women are going to have possible depression. They may have mild depression, or they may even not meet the criteria for depression, and, for example, have an adjustment reaction. Once you get to an EPDS of 13 or above, those women, if you go into a diagnostic interview, they're probably going to meet the criteria for major depression at that point. Depression becomes much more likely at that point. And a lot of times we get asked the question, what's the difference between baby blues and depression? So the biggest way to, the most reliable way to be able to tell the difference between these two is that baby blues, by definition, is less than 2 weeks. So if someone, say, for example, somebody presents and they say, I've been depressed for a couple of weeks, and I'm feeling bad about myself, and I've had thoughts that life isn't worth living, that would be consistent with depression. Versus, and I'm having trouble functioning or taking care of my baby, versus somebody who presents and says, it's been about a week, I find that I'm emotional, and my mood's going up and down, but I'm still enjoying things, and I don't feel like this most of the time, and I'm still enjoying my baby, and I'm able to do things. That's not likely to be consistent with depression. And by definition, the criteria for depression has to be 2 weeks. One of the other things we often get asked is, whether medications indicate or not. And I think regardless of whether you're treating patients and you're prescribing, I think it's important to be aware of this, because a lot of times, pregnant and postpartum women interact with so many women in the healthcare system and outside the healthcare system that are in either from a mental health perspective or what have you. And I think the more everyone can be sort of informed about this, I think the more helpful it can be. So in general, when we think about when medications indicate, if someone has a more moderate to severe depression, if they're thinking about their life isn't worth living, if it's affecting their functioning, and particularly if they have a history of severe depression, and if they have comorbid anxiety or other illness. So in general, when we're thinking about whether someone should be on medications in pregnancy, we're really asking the question, what could happen if this mom wasn't on medication? And what's the risk of that? And that's how we're really thinking about this. And for some women, the benefits of the treatment are going to outweigh the risks. And when we tend to less strongly consider meds is if someone has a mild depression, if there's no suicidal ideation, if they're taking care of themselves and their baby. Another big thing is if they're engaged in therapy. If someone's responded to therapy before, and if they're engaged in psychotherapy and they have strong preference for that, often those women might do fine, they might do well with psychotherapy. And in general, psychotherapy is really the mainstay of treatment. And medication for those that we think are not going to respond or they haven't responded, and we need to use both. In case you're coming across, say, for example, if you're screening women or you're working with pregnant or postpartum women, I want to just review the risk factors for suicide in general. So I don't have a magic ball to predict this, nor do any of my colleagues. What we do is we look at risk factors. The biggest risk factor for suicide is a history of an attempt. So often we're asking women, have you attempted before? If you have, was it lethal? Was it a lethal attempt? Was it recent? And we're really asking, do they have a plan or intent to do it? So for example, someone that says, I was thinking of doing it recently, I thought about it, I came close, that is very high risk, versus someone who kind of says, well, I think my life isn't worth living. I have no plans to do it. I know I shouldn't do it. There's a lot of reasons I want to live. I just sometimes wonder if my life is not worth living. That is generally not someone who needs to be hospitalized or would be at high risk of doing it imminently. And the other thing I want to comment on is risk of harm to the baby. So in general, people have, a lot of women actually have thoughts of harming the baby. This is actually very common. And there's two types of thoughts of harming the baby. And the reason for this slide is actually to reassure you, not to scare you, because actually most thoughts of harming the baby are actually low risk. So I'm going to give you a case example. So I saw a patient about a year ago, and she had obsessive compulsive disorder, or OCD. She had anxiety and depression. And she came into the visit saying, I'm really concerned that I'm having these intrusive thoughts about throwing my baby down the stairs. And she said, they're making me so anxious. I don't want to have these thoughts. I spend half my day pacing across to the other side of the house. I don't want to hang out near the stairs because this is making me so anxious. And I was not concerned that this woman would be high risk, that there was at risk of harming her baby, because she had good insight. She knew it was a bad thing to do. These thoughts were scaring her, and they were intrusive. She also was not psychotic. She knew it was a bad thing to do, and she knew that it wasn't. She knew that it would be bad for her baby, and the thoughts were making her very anxious. So that's someone who has thoughts like that is actually a very low risk of acting on that. That is very different than someone who has postpartum psychosis. So someone who has thoughts of harming the baby in the context of postpartum psychosis, now that is a psychiatric emergency. And that would be, so for example, there was a woman actually who jumped out of a very high-story building in Brooklyn a few years ago. And this woman had delusion. She had a delusion that her baby had a traumatic brain injury. She had seen a lot of physicians convinced that she had the baby had a traumatic brain injury. She thought that she caused it when the baby fell out of her arms one day, even though there was no evidence of this. And she had this persistent delusion, and she really believed this, and her reality was distorted. She ended up jumping out of a very high-story building in Brooklyn, and this is well known. It was in the New York Times at the time, and she holding her baby. She actually lived. She actually died, and the baby lived because she cushioned the baby's fall. And this is a case where, this woman had poor insight. She believed this. Everyone tried to convince her baby was okay, and she had this. She had a delusional belief that the baby had traumatic brain injury. And she also had psychotic symptoms because she had this delusion. This also sometimes occur in the way of people may have a delusion that the baby's evil, or the baby's the devil, or they may hear voices telling them that. Those are true psychiatric emergencies. And the difference is that these are ego-syntonic. So people may actually have an altruistic delusion that, like this woman, that woman who jumped out of that building in Brooklyn, really thought that she was saving her and her baby from a life of torture by jumping out of that window. She really thought that it was the best thing she could do for her and her baby. So she really had a distorted reality. And those are the patients that absolutely have to go to emergency room, and they're very high risk. But that's a very small subset of women. I'm going to talk a little bit more about postpartum psychosis, but that's a very small subset. It occurs in 1 to 2 in 1,000 women. This, however, OCD and anxiety and depression is very common, and having thoughts in context of that. The other thing I want to mention is bipolar disorder. So of women with depression, so in that same, there was a study where they screened 10,000 women for depression, and they went back and they asked them, when they screened positive depression, they did a diagnostic interview. They found that 69% of patients had unipolar depression, 23% of patients had bipolar disorder. So 1 in every 5 women who meet criteria for depression, who screen positive depression, could have undiagnosed bipolar disorder or could have bipolar disorder. That's a lot. So it's really important to be addressing bipolar disorder and thinking about that as we're thinking about postpartum depression. And the reason we care about that a lot is it's important to care about bipolar disorder in general because it's an important illness that needs to be treated. It's also important because bipolar disorder increases the risk of postpartum psychosis. As I mentioned earlier, postpartum psychosis occurs to 1 to 2 in 1,000 women, so much less common than perinatal depression. But of the women who are going to develop postpartum psychosis, more than 70% of them have bipolar disorder. So women with bipolar disorder are really the ones that are at high risk of this. And if bipolar disorder occurs, it's generally 24 hours to 3 weeks postpartum. It can often present with mood symptoms, psychotic symptoms. It is absolutely a psychiatric emergency, as I described earlier. And with postpartum psychosis, there's a 4% risk of infanticide. So I don't think I need to say more. This is just a really important illness that needs to be addressed, and we don't want to be missing this. And, women, I've worked with many women with bipolar disorder, and they can do very well with treatment. I think part of why we see this risk is because women may not be able to access their meds, they may go off their medication, and that's what presents the risk. But if we can help people actually get the treatment they need and deserve, then often we can mitigate a lot of these risks. So a lot of these women can have healthy pregnancies and have healthy bonding with their baby and a healthy experience. So I'm going to talk a little bit again about what do we do if someone screens positive. So say if you're working in a setting and you're maybe, whether being in a home visiting setting or a pediatric practice or what have you, and you're working with someone who scores positive on the EPDS. And I have the PHQ-9 here because that's the patient health questionnaire. It's also a validated screen that can be used in pregnancy and postpartum. And the scale is very similar to the EPDS as I described earlier. So if someone scores positive on the depression screen, that suggests, the patient's depressed. It's a screen. It's not a diagnostic tool, so it's important to perform an assessment of risk and assessment of depression. And, if practices have a co-located behavioral health clinician, they can often do that task. And it's really important also at that point to think about, let's refer the patient, the parent, to a previous mental health provider if they have one. Because if you're on this call and you aren't a provider yourself, or you may not, some people may not feel comfortable doing the assessment of risk or doing an assessment for depression, it may not be their role, then you can refer someone to a previous mental health provider. The other thing we recommend is, I'll go into that, there's a few other things we recommend, which is on the next slide. The other thing I want to note, if there's a positive score on the self-harm questions, patients can always be referred to a local emergency service. If you're somebody who works a lot with MassHealth patients, then you can contact a local emergency services program, which is listed there. And, if possible, if someone scores there, you want to have someone with the room and you want to be watching them to make sure that they're safe and that they're getting the treatment that they need. So if the EPDS is greater than or equal to 10, but it's less than 13, which indicates that, they may have sort of this minor depression, or it may not meet criteria for major depression, but, they're having some symptoms, then at that point, the patient may be able to get some mental health care on their own. At that point, what we recommend, it depends. Some women may have a score in that range and still feel like it's really hard, because I'm sure, as we all know on this call, on this webinar, the mental health system is really hard to navigate. I'm sure I don't have to convince any of you of that. And so what we recommend there is giving mom information about community resources and support groups. We have some MCPAP for Moms resource cards, which if you contact me after this, I'd be happy to link you to someone who could send those to you. They say having a baby is challenging. Every mom deserves support, and they refer to our website. Our website has a lot of educational resources for women, and it also has, people can put in their zip code and actually search for a support group. We also recommend providing the names of mental health providers in the area who treat postpartum depression, and we can encourage providers that you can encourage the patient to have their provider call MCPAP for Moms, and also the patient to visit the website. And as I mentioned, a lot of times we get calls, so someone identifies depression in the community, and they encourage the patient to call their provider, or they call the provider themselves, and often we have providers call us due to that. It does, we do have that happen quite a bit. And it also helps to empower the patient to call, but also maybe for you to call and let them know that, as we say here, once you get the patient's consent, notify the PCP or the OB or whoever their provider is to be able to, call the patient and follow up with them and potentially treat them and link them with therapy, and we can help with that. And if the patient meets, if you're concerned about their safety, then, you can also contact the patient's provider, of course, and you can also recommend the provider call MCPAP for Moms. We're certainly here to be able to, we actually take calls when people are concerned about people's safety quite a lot. We're not an emergency service. However, we've definitely taken calls from people. For example, an OB recently was seeing a patient, and they really felt like they needed to send the patient to the hospital, and we can help them figure out how to do that, because OBs may not feel comfortable knowing how to do that. And I recently took a call from a pediatric practice where someone had expressed concern about the patient. The patient came into the office. The pediatrician was trying to figure out, should I hospitalize this woman? Should I send her to the ER? And we sort of helped him, think about what's the criteria for hospitalization or not, or for sending the patient. And we're happy to provide consultation on that. Although, as I mentioned, we're not an emergency service. We can certainly help with someone figure out how to navigate that process. And if it's not an emergency, we can also help with care coordination for outreach, for therapy, and other mental health care in the community. Also important to be engaging natural supports. So, if you're with someone and if you're with someone who's screened positive, you want to make sure that as much as you can, that the patient's engaging in natural supports, which seems intuitive, right? But it may not be intuitive to a parent who's feeling isolated and depressed. So, and if a parent's feeling alone, or they are alone, there's a higher risk of suicide. So important to, after getting the patient's permission, to notify their natural supports if you can do that. Also important to think about and be screening for domestic violence. The other thing we want to know is that it's really important to be thinking about education about the various treatment and support options. So we've talked a lot that providers call us a lot with medication questions. That's certainly a part of the treatment. Individual psychotherapy is really important, and we help connect people with resources for that. And also support groups. And as I mentioned, we have the support groups available on our website and can help. That's something women can go themselves, put in their zip code, and actually look for a support group. So a lot of times we get questions about medications and pregnancy. And whether you're a prescriber or not, I think this is really important information for people to have, because the more sort of the medical community and anyone working with pregnant or postpartum women or interfacing with them understands this, the more we can sort of dispel some of the myths around this. So I think, there's really kind of a few key things here. One is that there are effective treatment options during pregnancy and breastfeeding. It is not, I think there's sometimes a myth that women are pregnant, they need to suffer because that's best for their baby. That is absolutely not the case. The best thing a woman can do for herself and her baby is to get the treatment she deserves. Sometimes that's therapy, sometimes that's medication. And depression is really common, and we have options that work. And there's also no risk-free decision. So a lot of times a woman may think, well, I'm going to suffer and I'll just not take any medicine because it's best. But we know that the exposure to illness has risks as well. So a woman is not doing herself any favors, nor is her provider, by not giving her the treatment that she needs, whether that's therapy or medication. And it's also important to note that women take medications in pregnancy for a lot of things. In my experience, women often don't really think twice about taking their medication for their nausea, but they may think twice about their antidepressant medication, because sometimes those medications are sort of seen as they're dispensable because it's for depression, not for nausea. But these medications, they're actually the best studied class of medications, antidepressant. Out of all the medications for any illness, they're incredibly well studied, and overall they appear to be safe. And we just want to dispel the myths and let women know that the most important thing is they're getting the treatment they need and deserve. And sometimes that includes medication. And so the other thing is that we provide linkages with support groups and community resources, I mentioned. And I want to mention that we partner with Mother Women. They're a community organization who helps us to build support groups. They also have a community-based perinatal support model, and we work with them to help build the capacity of the community to address depression. We're very thankful for the work we do with them. And also we work with William James College. They build our care coordinators, have a database of the whole state, and when we provide care coordination, we match with the patient's insurance and whether they're taking patients, and we partnered with them to be able to create that. And really the goal of all this is to support the wellness and mental health of pregnant and postpartum women. And having a baby is hard for anybody. Even whether someone has depression or anxiety symptoms, having a baby is always hard. And really we want to support the wellness and mental health of perinatal women, and often that can be done whether they don't necessarily have to meet the criteria for some illness for that. And this is our card I was describing. And this is something, and again, we're happy to send these cards if anyone on the webinar would like them. I can link you with the person who could send these to you. So these are something that we can hand it out. Our goal here is to sort of, again, be just normalizing this. This is really hard. Every mom deserves support, and they can go on our website and look for some information and look for a support group. And this is our website. So the psychoeducational material I was describing is all under the Mothers and Families tab, and that's where you can look for the support groups. And then all the toolkits I described are under the provider toolkit. And another resource we have for people is that we want to encourage women to empower them to talk to their healthcare provider. So what we can do is we created this sheet if someone is pregnant or just had a baby, they're worrying about the mental health, we want to encourage them to talk to their healthcare provider and encourage them, what do they say? Because this is actually can be very hard for women sometimes. So this is something that, again, this is available on our website. It can be printed out. That if you're working with women, you can give this to them in order to sort of help them know how to talk to their healthcare provider about this. So I'm just going to give a brief case example of if you have a patient, if you are working with someone, and just to sort of exemplify some of the points about medication use during pregnancy. So a woman presents, she's 10 weeks pregnant, and she tells you that she's on a medication called, bupropion or Wellbutrin, which is one of the newer antidepressants. Lots are new now, but still newer than something like Zoloft. And she says, I'm on this medication. Her EPDS is a 9, so she's doing quite well. She's been very depressed before and really had trouble functioning. And she says, I went to Google, I looked up Zoloft, which is an older first-line treatment, and she says, I want to switch to Zoloft because I heard there's better data. And the reason I would say that you would not want to tell her that, or, again, whether you're sort of counseling someone as a prescriber or not, but just to understand the concepts here, is that, say, right now, she's had one exposure. She's had exposure to the medication Wellbutrin. And yes, there's more data for Zoloft than Wellbutrin, but overall, the risk of the antidepressants overall seem to be pretty similar among the classes. So, but if someone stopped the Wellbutrin and started Zoloft, she could have 3 exposures: exposure to illness, exposure to the medication, which she's already been exposed to, and exposure to a second medication, Zoloft. So you've gone from 1 exposure to 3 exposures. So in general, when women are pregnant or lactating, it is not the time to change medications, and it's best to continue medications that are working. So just a concept to get across if you're interacting with women and they may be asking questions around this. And obviously, if you're not providing direct treatment, you can refer them to a medical provider. And so in general, to sort of summarize, it's important to balance and discuss the risk and benefits, but you want to be weighing the risk of untreated treatment as I described. And again, no choice is completely risk-free, and you can always either call yourself if you're a prescriber, or encourage the provider or encourage the patient to have their provider call MCPAP for Moms, because we're happy to talk about these things. One note about breastfeeding is that in general, breastfeeding generally should not preclude treatment with antidepressants. They're generally considered a reasonable option during breastfeeding. And I once read an article that said you'd have to breastfeed exclusively for 2.5 years to equal 1 month of exposure in utero. So once someone's been on medication during breastfeeding, it really doesn't make any sense to stop it postpartum. And those same rules apply when people are breastfeeding, that you want to use medications that's work, and it's generally not a time to switch medications. So in summary, our aim at, for all the work that we do, and particularly with MCPAP for Moms, is to promote maternal and child health by building the capacity of frontline providers to address depression. And I'm happy, the contact information, I'm happy to answer questions. I think we have the allotted time, so.
Yes, one of the people were wondering if you'd be able to quickly go through, maybe not talk about them, but quickly show the slides that we missed.
Oh, sure. So it stopped going through from slide 21 to which one?
To 32.
Okay, 21 to 32. Yep, I can show those slides. Sure. So this sort of talks about what you can do, which I talked about, encouraging family members, encourage mom to call their primary care. This describes sort of the what happens when you call MCPAP for Moms. Talking about, we encourage both OB and pediatric providers to screen. This describes the screening time points. So first, twice in pregnancy, once postpartum, and 2 weeks postpartum for high-risk patients. This describes our screening at pediatric visits. First month, 2 months, 4 months, 6 months. This is the code, the S0005, when we can screen. Screening is now reimbursed once during pregnancy and once postpartum for MassHealth patients. This talks about the bidirectional relationship with infertility. Our summary of preconception planning being critical. Risk factors. And I think that's where we started, right? And then this is a photo of the EPDS. Is that helpful?
Yes, thank you. We haven't had any questions come in quite yet. Was there, and we still have some time, was there anything you want to elaborate on until we get a question in that you felt that you could use more time on, or?
Yeah, I'm curious to know, I mean, let me go back to this case. So I think I'm actually curious to know a little bit from the audience as to whether if people are interacting with patients in these settings and what kind of, I know it's a diverse group, and if people have questions about, because a lot of times we get questions for people that aren't, if someone's not a prescriber, how can we use this program and is it helpful? And I'm sort of happy to answer questions around that, and if people have any questions around doing that referral piece. Because a lot of times people do, as I mentioned, we certainly get calls from providers because moms told them to call. And also I wanted to add that patients don't call us directly either. So our goal is really to build the capacity of the frontline provider to address depression and also other mental health concerns. So we don't take calls directly from patients. They have to either go on our website or they have to talk to their provider, and their provider calls us. And sometimes people have sort of questions around how they navigate that.
We do have a question. She's
Yep.
asking, can Dr. Byatt ask what specific forms of psychotherapy have been demonstrated by good research to be effective for this population?
Yeah, that's a great question. Yeah, so the great news is we do have evidence-based psychotherapies. So the two psychotherapies that have the really strong evidence for use in this population is interpersonal psychotherapy and cognitive behavioral therapy. There's a very strong evidence base for both of those types of treatment. I mean, with cognitive behavioral therapy, that's evidence-based treatment for non-postpartum or pregnant populations. So that makes a lot of sense. And with interpersonal psychotherapy, if you think about the transition, moms transitioning to having a baby, there's a lot of role transitions going on. So IPT, or interpersonal psychotherapy, can be very useful, and it's particularly targeted in this population because it's a huge transition to have a baby. It rocks the marriage sometimes, or the partnership, relationships with in-laws, parents. I mean, there's so many role transitions that happen during this time period, and interpersonal psychotherapy can be very, very helpful to sort of help women navigate that. Because whether someone has any illness or not, that's pretty typically it's just a difficult transition. It's extraordinarily challenging. And now we have some more research. So support groups have, the evidence for support groups, I would say, is more it's more mixed. There's some evidence support groups can be helpful, but there's some evidence that maybe they're not, so that the evidence for support groups overall is mixed. And there's also some evidence for peer support interventions, whether that's done individually over the phone. The evidence for group-based peer support is more mixed.
So could you possibly talk about how to find a provider who is truly well-trained in and is doing these specific forms of cognitive behavioral therapy, or in the Weissman and Klein-Klierman interpersonal psychotherapy?
It's a great question, and I wish I had a better answer. I think it's really hard, actually. We have these evidence-based psychotherapies. It's very hard to know whether like in our database, we know what people say. So certainly people call. I absolutely ask our care coordinator, can you please link people with like IPT or CBT or these different types of psychotherapies? However, it's very hard because we know that they work. Whether people are really adhering to sort of evidence-based psychotherapies in the communities, often we experience that as very difficult. So we do our best, and we try to do that. I mean, one way is, we can certainly be helpful with that. We do find it challenging to be able to know whether they're really adhering to those treatments. So even though we do include in our database what types of therapy they practice and things like that. One of the things that I think is really exciting is we now have a lot of sort of online interventions. We have less of the problem in Massachusetts with this because we tend to be we're not such a geographically big state, and while it never feels like we even have enough resources here, we have a lot more resources than a lot of the rest of the country. But there's some exciting work being done on online interventions, both using apps, using online CBT, and a lot of online interventions that are being shown that have some really good, they're beginning to have a good evidence-based. And the good thing about that is, it's sort of an evidence-based treatment, and often that can be supplemented with some counseling. So a patient, for example, does a module online and then has some sort of phone contact with a therapist. So those are some interventions that I'm hoping will make sort of truly evidence-based treatment more accessible for women, because I do think that's a major challenge in our field. We have great therapies, but actually really getting those true evidence-based therapies to women, I think, is a major challenge. I think it's a great question.
All right, thank you. Another question is, and this may be more of a comment, to my knowledge, there is no one who is actually trained in IPT in Massachusetts. Someone might say they can do interpersonal psychotherapy, but not actually be trained in it per the protocol developed specifically by Weissman and Klerman. Do you know anything about that, or is that not something you'd want to comment on?
Well, I think it's a good point. I mean, I think that I think it's pretty consistent with what I was just saying. I mean, you're right. We have, in our database, we know that people sort of advertise or they do IPT, but whether people really follow a sort of true evidence-based approach is really difficult. And I think I appreciate the comment, and I think it's a good one, because it is very hard to know whether people are truly following evidence-based psychotherapy. And I would just reiterate, I think it's a major challenge, and I really, I appreciate the comment, because I think it's tough.
All right, well, thank you, Dr. Byatt. When we post the slides and the webinar recording on Spark's website, we'll make sure that we have a link directly to MCPAP for Moms, so folks can go right there from our website if they want to see what you guys have on your website. And Dr. Byatt is a Spark faculty member, so if you need to get in touch with her directly, you can find her contact information on our website as well, or you can contact me, and we can forward your questions directly to Dr. Byatt, and she can answer them.
Yeah, sounds great. Well, thank you, everyone, for your attention and for listening, and I hope it was helpful.
Thank you so much. We really appreciate you taking the time. And
you're welcome.
There should be a brief survey that will pop up after the webinar. And we'd really appreciate it if those of you who stuck around could fill it out for us. We love to get your feedback. And I know there was a glitch with the slides, which I really apologize for. But I hope you all do well and have a great afternoon. Thank you so much.
Thank you.